Okay. Sai is again telling us about shallow anterior chamber, but this time with high intraocular pressure. Sai is, one of the senior most glaucoma people in Kerala. He works as a senior consultant in Giridhar.
Thank you. Thanks for having me in this course. I think we have been doing the same course for the past 3-4 years. And George has been telling us that most of the vision-threatening complications of TRAB are due to hypotony. Well, I'm going to show some due to high pressures as well. So these are just 1 or 2 introductory slides. So basically, we're going to talk about this area. Okay, so you have a flat anterior chamber following trabeculectomy, but the pressure is very high. So what are the options or what are the possibilities that you're thinking of? First one, simpler one to think of is pupillary block, okay, due to various reasons. Second is a delayed suprachoroidal hemorrhage, and third is a malignant glaucoma, or what we call an aqueous misdirection. So we'll just go into one by one in slightly more detail. Pupillary block is usually the first differential when you have a flat bleb with a raised IOP. So the Seidels is negative. There is a bit of iris bombay. The peripheral iris is coming towards the cornea. The AC is shallow peripherally, but the centrally the AC is well formed. And the PI may be patent, may not be patent. Even if you think it is patent, some of the iris pillars can block and cause a pupillary block. And simply treated with a laser iridotomy. So this is one situation where early in the post-operative period, you may have to employ a laser iridotomy, although it's not the ideal scenario because the eye is still a bit inflamed. But sometimes you may have to do it somewhere in the mid-periphery, not in the exact location where you would normally like to have a PI, but it relieves the situation, relieves the pupillary block, and a few shots later you can see the aqueous coming out, and in many cases it just settles down. Suprachoroidal hemorrhage, as we all know, as cataract surgeons, it's a very deadly, thing that we don't want even to dream about. It can occur late after a trabeculectomy, especially in patients with these sort of risk factors: advanced age, hypertension, high myopia, prior vitrectomized eyes, severe post-operative hypertonia. These are the situations where you can have a suprachoroidal hemorrhage. So abrupt loss of vision, and patients present with systemic symptoms like nausea, the eye is very inflamed, both the peripheral and central anterior chamber are flat, very high IOP, and very, very importantly, loss of red reflex. So you won't have any red reflex, and then you have to do a B scan and see whether it is an actual suprachoroidal hemorrhage or not. And you may need serial B scans over a period of time to see how it is getting liquefied. Small hemorrhages usually resolve spontaneously. The large ones require drainage once it is liquefied. The timing of drainage is always controversial, but never do it immediately. Wait for a few weeks before you do a suprachoroidal drainage. The third one is the malignant glaucoma. So this is a third diagnosis once you have excluded pupillary block and suprachoroidal hemorrhage. Occurs early in the postoperative period. Shallow anterior chamber both in the center and the periphery, very high IOP with a patent peripheral iridotomy. So we know how it occurs. There is anterior movement of the ciliary processes. There is posterior misdirection of the aqueous. The aqueous collects behind the retrolenticular space or behind the IOL if it is a pseudophakic eye, and pushes the entire apparatus forward. So this is the UBM and OCT pictures of the malignant glaucoma. So the treatment is aimed at controlling the intraocular pressure and formation of the anterior chamber. So this is one point that has to be very, very clearly noted. So in mild cases, you can go with medical management, cycloplegics, some anti-glaucoma medications, and you can slowly withdraw the osmotics first and then the ocular hypertensives. But last, withdraw the cycloplegics. Keep the patient on hometropine or atropine for a significantly long period of time. Management with laser peripheral iridotomy, of course, that will rule out a pupillary block. In an aphakic or pseudophakic eye, if you can do an ER capsulotomy with the anterior hyaloidotomy. So one most important point to be noticed here is that it is not just about the decompression of the vitreous alone, it is to create a connection between the anterior chamber and the posterior chamber. That is the definitive treatment of a malignant glaucoma. So even if you do, we have had cases where we have had typical malignant glaucomas, we've done a pars plana vitrectomy, but the PC is intact. Sometimes it recurs, sometimes the whole thing comes back. So you have to have a connection between the two chambers, and that is the only way where you can prevent these. The original surgical treatment was described by Chandler. This is Dr. TG's video, which again I have been showing for. Sir, in the video, can you play, sir? Again, showing for a few years now, including the All India Conference. So this is a typical Chandler's procedure. I don't think this is the standard procedure that is used anymore nowadays, because you have to penetrate through the zonular portion also and then go behind so that you create a passage. So easier probably now again, if it is a pseudophakic eye, do a do a YAG capsulotomy and then a pars plana vitrectomy so that the connection between the two chambers is maintained. So this is, here you can see that once it is relieved, you can easily inject, see that the AC is formed, you can actually inject fluid or air inside the anterior chamber. So post-operative management in filtering surgeries is actually more challenging than the actual procedure itself. A good pre-operative evaluation, meticulous intraoperative technique, all are very important for a key and successful outcome. Thank you very much, Dr.